Welcome to Chapter 6. So we're going a little bit more into, and you'll see some repetition from the red blood cell PowerPoint. We're going to go more into oxygen transport in the bloodstream. So once we get it past the alveolar capillary membrane, how does it really get from the membrane through the membrane and then into the bloodstream? And that's one part of this whole thing. But once it's in the bloodstream, how does the oxygen get to the tissues to be used? Because if we can't deliver the oxygen to the tissues, if we can't get that oxygen content in our bloodstream and then deliver it, then a lot of this is sort of useless. So you could have the world's greatest diffusion of your alveolar capillary membrane, but if you can't send that oxygen, if the oxygen can't bind to the hemoglobin, if it can't exert enough pressure in the plasma, if it can't be transported then to the tissues in a way that's useful to the tissues, then it's going to be pointless ultimately, because the whole idea is to get oxygen into your tissues and to get CO2 out of your tissues. So that's where a lot of this is going to come into play. And then we're going to introduce some content equations here. Now, the content equations are going to look very similar to each other, so you will be fine there. We'll go through it one after another, but there's some equations that we'll work on here, and let's just take it one step at a time. So when we're looking at this is the alveolar capillary membrane here, and here would be the alveoli, right? Here, and then the capillary over here that has both the plasma and the red blood cells that are passing through it. So when we're looking at this, we want to see how easy it is to transport oxygen onto that red blood cell and to get CO2 off of that red blood cell, as well as how easy it is to get oxygen into the plasma, as well as to get CO2 out of the plasma. Now there's two ways oxygen is transported, remember? It's transported in both the plasma and on the red blood cell as far as oxyhemoglobin is concerned, right? That's the fancy word for hemoglobin on the red blood cell that's bound with oxygen. And just remember, the AC membrane, when we're going through the AC membrane, the thicker this membrane is, the harder it is to get that diffusion, right? And that's part of that Fick's law when we were looking at that earlier, is the thicker the membrane, the harder it is to diffuse. The thinner the membrane, the easier it is to diffuse. So when you have something like pneumonia, when you have something like pulmonary edema, where there's a bunch of fluid just building up in the alveoli, when you have scar tissue forming like pulmonary fibrosis, it's going to make it very hard for oxygen to get into the bloodstream in the first place, right? That's where we're going to see your giant A to A gradients. Remember, A to A gradient is looking at how easy it is to get from the alveoli into the little arterial, right? That's ultimately what it's looking at. How easy it is to get over there. And so the bigger the A to A gradient, the harder it is to get oxygen to the bloodstream. That means we have a diffusion issue, we need to overcome that with more pressure. Because remember, ultimately when it comes down to it, this is Henry's law. The more pressure, so if we increase the pressure in the alveoli, then we'll be able, according to Henry's law, right, more pressure means more diffusion, we'll be able to increase the pressure in the artery. So by increasing the alveolar pressure, we should be able to help increase the arterial pressure, right? And so that's the whole idea here. When we have a patient that has very low oxygen levels, very low P little AO2, right? If their P little AO2, let's just say, is 50 millimeters of mercury, that's very low. And so how would we treat this? How would we help this patient get an appropriate pressure of oxygen in their bloodstream? Well, we know that we can increase diffusion, or increase the amount of oxygen going into the plasma, right? Because PaO2 is how much oxygen there is in the plasma. We can increase this if we therefore increase the alveolar oxygen. Well, this is where, hey, knowing the alveolar air equation comes in very, very handy. So remember the alveolar air equation, we're looking at FiO2, pressure, and then CO2, right? So what are 3 ways we can increase our alveolar oxygen pressure? Well, one way is to increase our FiO2. If we increase our FiO2, that increases your alveolar oxygen pressure. If we increase the driving pressure of the machine, right, or if we put you in a hyperbaric chamber, right, we're delivering that extra pressure to help diffuse oxygen, or we can get rid of CO2. If we get rid of CO2, there's less um, tension in your alveoli taken up by CO2, and therefore it will give more room for oxygen to exert its pressure and therefore diffuse a lot better. So if someone's hypercarbic, usually we're going to deal with the CO2 problem before we increase pressure, increase FiO2. Now that can change, especially when we get to mechanical ventilation, but traditionally if someone's CO2 level is really, really high, we're going to fix that problem first. Now there's a situation down the road you'll get to. You don't need to remember it now, so you can do a little zone out moment here, but where if someone's CO2 levels are high, and we might actually keep their CO2 levels a little bit high. It's called permissive hypercapnia. I'll say that again, permissive hypercapnia. And we'll leave their CO2 levels a little bit high. And we do this on purpose because just like having a broken leg, if you had a broken tibia and fibia, would you want to walk on it normally to and from? Would you want to do your daily exercises on that broken leg? Or is it best for that leg to heal and not be used as much until it's healed? Well, the idea there is you need to rest that broken leg and let it heal. Well, if our lungs are sick, if we have really sick lungs, a really bad viral pneumonia, let's just say, and we're building up scar tissue, we have very, very bad scarred up tissue, if we breathe at a normal rate, right, we're still expanding and collapsing the alveoli, well, we can actually be damaging that alveoli even more than what's going on with that viral pneumonia. So we're actually causing them to be worse. So the analogy here is it would be like someone having a broken tib-fib on their leg and still walking on it, right? Are we going to let them walk on it, or are we going to let them rest and be a little less mobile for a little bit? So on these patients that have really sick alveoli, like in the case of a severe viral pneumonia, we might let their CO2 levels be a little bit higher than normal to allow for their alveoli to take a break from moving as much. I hope that makes sense. In that case, usually we'll focus on FiO2 and pressure from our breathing machine, from the ventilator, traditionally. So those are other ways we can do this. So just understand there is a case where we may not correct the CO2 to a normal level. We might let it be high for a little bit just to let the lungs sort of heal. And in the meantime, while the lungs are healing, just like a broken leg, in the meantime, while healing, we're going to work on the other factors that we have here, which would be FiO2 and pressure, to help get better oxygen levels in the bloodstream. So remembering the alveolar air equation and your 8A gradient is going to come in very handy. And in fact, there's something that we use called the PaO2 to FiO2 ratio, where we actually just divide the two, right? And so that's looking at how much oxygen that's available in the alveoli versus how much is getting into the arterial. So does that sound very familiar to your 8A gradient? It should. Right, so this is a screen. This is a screen directly from ARDS. So when we're looking at an injured alveoli, so this is sort of the normal case of an injured alveoli. So over here on the left is your normal alveolus, right? And so when you're looking at this, you see your type 2 cell, which creates surfactant, and your type 3 cell that gobbles up all the bad stuff that might be down there. Right, and most of this, you have this little surfactant layer down here, and that surfactant layer just helps lubricate, just like grease and oil in your engine. It helps lubricate the parts of the engine so that way they don't rub and tear against each other. It helps neutralize the places a lot. It helps decrease surface tension. Once again, I'll say it again. It helps decrease surface tension. In other words, it's there to help keep the alveoli open at resting. All right, so these are all normal. The type 1 cell is just the wall of the alveoli itself, right? Every once in a while, you have a fibroblast, right? There's a blast from your past, right? That's hanging around, but overall, nothing bad's going on there, right? You have your endothelium of your arterial, you have your red blood cell, all that other stuff. So this is a normal, healthy alveoli on the left. On the right, when an injury happens, right, we're going to see a lot of stuff change. And this is when we see patients with severe viral pneumonias or a syndrome called ARDS. And so what happens here is we even have the epithelium in the lung sort of sloughing off, right? We're going to have a bunch of fluids just to start to invade that area. So just like if you've ever rolled your ankle and it's swollen up, or if you ever injured a joint and it's swollen up on you, that's what you're looking at here. And the same process is going on that happened in your ankle when you rolled it to now happening in your alveoli, in your respiratory zone, right? So it's going to fill with a bunch of fluid, right? You're going to have even red blood cells that end up going in there. So all this stuff that's filling up in here, it's going to fill up that tissue. It's going to dilute and inactivate the surfactant. In other words, the lung tissue is going to be more prone to collapse. That's a bad thing, right? If the lungs are more prone to collapse, that means we have less surface area to get oxygen into our bloodstream and to get CO2 out of our bloodstream, right? We're going to have neutrophils that get activated. We're going to have leukotrienes start to be filled in. We're going to have oxidants, so now you're more prone to oxidative injury. You're going to have proteinaceous. You're going to develop a lot of protein that's going to develop in there. It's going to be like pus, right? Like pus that's ultimately developing with everything that's going on. You're going to have fibrin that starts to form, and that's the stuff that starts to make this alveolar capillary membrane really, really thick that you're seeing here, which means the thicker it is, the harder it is for oxygen to diffuse. Not only does it have to now go through all this fluid, this edema, but now it also has to go through a thicker, swollen membrane as well. So that really limits the ability for oxygen to cross over and diffuse into the arterial, into the capillary, right? So we're going to have a lot of issues going on here, right? And ultimately, if this continues to go on, if this injury continues to go on, we can form hyaline membrane, right? The scar tissue. And scar tissue is not flexible, and it's not easy to diffuse gas through scar tissue because the scar tissue thick or thin, right? Scar tissue is very, very thick, and it's very hard to diffuse gases through it. And so we're going to have a big issue, not only short term during this acute phase up here, but if this continues to go on, if we don't let the lungs heal, if we don't take protective measures for the lungs, in other words, be gentle with how we ventilate them on the ventilator and so on, it's going to be exacerbated to a more long-term issue. It's pretty bad. And so we even see endothelial cells of the arterioles start to get swollen, which then not only is your AC membrane, your alveolar part of the membrane getting thicker, but the capillary part of your membrane is also getting thicker. In other words, that lining that the oxygen has to go through is also thicker. So now this is a double whammy, right? We're going to have an issue getting oxygen not only through the alveolar wall, but also through the endothelial part of the capillary as well. So this is a double trouble, right? This is a bad situation. So it makes us have a hard time getting oxygen into these patients' bloodstreams. No matter how much FiO2 and how much pressure you give them, you could still be deficient in the oxygen level getting into their tissues. And so that's something that we need to be aware of. When we have a patient that's on high FiO2s, when we have a patient that's on a high amount of pressure, those can all cause issues where if we're not getting that oxygen to the bloodstream where it can then be used by the tissues, then it's useless, right? So we need to look at strategies to help get them oxygen into their bloodstream directly if we have to, in order to help their body stay functional during whatever process caused this ARDS, right? And one of the main causes of ARDS is not necessarily a viral pneumonia. It's usually caused by sepsis, and that's a blood infection where your whole body swells and inflames. So there's a lot of things that can cause this, right? A lot of things that can cause ARDS. Aspirating food or vomit or foreign material. You could have a systemic inflammation. I had many patients that were trauma victims where they were thrown from a vehicle or something like that, and their whole body was just inflamed and swollen, and that led ultimately to ARDS, because if it's inflamed and swollen systemically, that includes your lung tissues, right? And so you're going to see this in a lot of different situations, and that's where we come into play. We know the alveolar capillary relationship very well, right? You are now being trained to be an alveolar capillary therapist. Understand that relationship well, right? You're going to be that relationship expert for the alveolar capillary membrane. And so the idea here is then you understand, hey, what factors go into increasing someone's P little AO2? What factors go into increasing the oxygen content of their bloodstream? And so that's where we're at now. And I'm here to help you understand how to get better oxygen content into a patient's bloodstream. And one of the things not covered in this presentation is Ecmo. Ecmo is extracorporeal membrane oxygenation. In other words, we take the blood out of the body, we run it through a machine, and then we dump it back into the body. Now, there's a couple of different types, but in general, one of them is where we take it from a vein, put it through oxygen, get oxygen into the bloodstream, and then put it back into a vein. And so we sort of bypass and just mimic the copying of what the lungs do. So if the lungs are very sick, they're in this disease state that you see here on the right, then we can actually manually do this and bypass this. And you as an RT can run this. Yes, you can look this up. There's even past graduates of mine that are doing this at local Colorado hospitals as well. So that's something that we can do there. Or if the hearts and the lung are both sick, we can bypass both the heart and the lung and take it from a vein and dump it into an artery after it's been oxygenated. And so that's something too, we can help the heart recover, right? If the heart's very sick on top of the lungs. So there are options to help get oxygen levels in the bloodstream a little bit higher. And you'd be like, Derek, why is this not the first line of thought? Currently, as of recording this, there are risks of infection and bleeding. There are risks associated with every procedure out there. So the risks of Ecmo have to the benefits of Ecmo have to outweigh the risks of Ecmo when you're looking at it. And all the evidence that I'm aware of currently says the earlier it's done, the better the results, but you still have to weigh the risk versus benefit ratio on your patient. Could they still benefit from a different way of using the breathing machine? Could they still benefit from putting them in prone position versus supine position, right? These are all things that we have to look at as a care team and decide in this specific patient situation, what would be best for them and what does the evidence support? And so you'll get into that down the road, but I just want to give you some ideas of what you might see. All right, so I got some questions about perfusion versus diffusion limitations. So we'll go over it again real quick. And remember, repetition is the key to learning. So nitrous oxide, N2O, conveniently known as laughing gas, is also used for general anesthesia as well. This is something that where the gas moves across the AC membrane and into the plasma. It doesn't attach itself to hemoglobin like oxygen does or carbon monoxide does. It just goes into the plasma. It has no attraction to the red blood cell, and so it just perfuses into diffuses into the plasma where it builds up pressure, right? Because any type of gas that goes into the plasma will exert a pressure, okay? It's not chemically bound to hemoglobin, so therefore it still exerts a pressure, okay? So this one does not bond with the hemoglobin. So it goes into the plasma until it reaches equilibrium. So let's say I have an alveoli up here and a capillary down here. And let's say I have a pressure of N2O of, let's just say it's 20 millimeters of mercury. So this is going to continue to diffuse into the plasma until the plasma reaches 20 millimeters of mercury. Once it reaches equilibrium, there's no pressure gradient. It's going to stop diffusing once it reaches that equilibrium. So when that equilibrium occurs, no more is going to go in there. So the only thing that stops this gas from being diffused into the bloodstream is equilibrium. So the faster that blood moves, if I make this blood really go fast, if the faster that blood moves, the more will diffuse into the bloodstream. So what do I mean by that? So if I had really high blood pressure or good blood volume or high heart rate, right, where I'm sending a lot of blood really fast through the alveolar capillary bed, then I'm going to reach that equilibrium, but just as soon as I reach that equilibrium, new blood shows up in the alveolar capillary relationship. And then once I reach that equilibrium, new blood's going to show up and I'll reach that equilibrium. So it's all about that equilibrium. The only thing that limits that diffusion is going to be how much perfusion is there. So the only thing that limits how much of this gas goes into the blood is how much perfusion, and that's why it's called Perfusion Limited, right? So the only thing that will limit the amount of nitrous going into someone's bloodstream is how much blood is going through there, and that's what limits it. So the only thing that slows down how much nitrous gets into the bloodstream is how much blood is perfusing past it. So what determines the rate of diffusion, right? Since the gas diffuses faster than the blood, the rate of perfusion, or how much blood is flowing past it, determines how much of that gas gets into the bloodstream. So over here, I have a patient with low blood pressure. And over here, I have a patient with high blood pressure. So if I have a pressure of nitrous of 20 millimeters of mercury, 20 millimeters of mercury, so both pressures are equal, but one has hardly any perfusion going past there. The other one, lots of perfusion, lots of blood volume, lots of pressure, right? Lots and lots of blood going through that area. So in this scenario, which patient is going to have a lot more of the gas enter their bloodstream? Well, hopefully you said, hey, this patient only has 20 millimeters of mercury over here and 20 millimeters of mercury over there, but on the right, hardly any blood flow is going in there, and so therefore we're going to reach equilibrium pretty quick in this area. And then it's going to be a little while, because remember, it's going to take longer for lower blood pressure for this next area to show up. So we're going to have a lot better diffusion. We're going to have a lot more of the gas enter their bloodstream faster if their blood pressure is higher, or their heart rate is higher, or their blood volume is higher. That's going to equal out to having a much better diffusion, or a much higher concentration of gas in their system much faster. So since the gas diffuses faster than the blood flows, the only thing that limits how much gas goes into their system is the perfusion, or how much blood is flowing through that capillary membrane. And this is called perfusion limited gas flow. Why do I make a big deal about this? We're like, we're not anesthesia, we're not the ones usually giving this gas. Well, here's the thing. Under normal pulmonary conditions, in other words, you have a healthy alveolar capillary relationship, The only thing under your normal conditions that's going to limit how much oxygen gets into your bloodstream is the perfusion past it. So under normal, non-diseased lung conditions, your body is perfusion limited. So that means in this situation where you have high blood pressure, if you increase someone's heart rate, if you increase someone's blood pressure, you will then increase the amount of oxygen that can get into the bloodstream. So this is why if your body's hypoxic, right? If your body has very low PaO2 levels, very low saturation level, your body responds to hypoxemia by what? It increases blood pressure, it increases heart rate. Well, does it make sense why this would be a response to hypoxemia? It does this on purpose to help you get more oxygen diffused into your bloodstream, to have more oxygen content in your bloodstream, right? So this is all, like I said, assuming a normal alveolar capillary no lung disease relationship here, okay? So under normal conditions, your blood is the only thing, how much blood is going past your alveoli, is the only thing that limits how much oxygen level is in there. So the faster your heart beats, the stronger it beats, the better the ability to get oxygen into your bloodstream, right? And that's your normal physiologic response. That's why if we give a patient that's hypoxic, right, that's hypoxemic, right, where there's low blood, emic is in the bloodstream, right? If a patient's hypoxemic and we give them a lot of oxygen and it improves their oxygen in the bloodstream, what will happen to the heart rate and the blood pressure? Well, if we give it to them, and this patient here, right, this is their physiologic response to hypoxemia. If we give them enough oxygen to satisfy their body of oxygen in the bloodstream, what will you see happen to their blood pressure and the heart rate? Well, they should start to return back down to normal levels. So the heart rate, instead of being 120, should now drop to 110, 105, 100, right? It should start slowly coming down. Same thing with their blood pressure. It should start slowly coming down. That's a sign that the oxygen that you're giving this patient is being therapeutic. In other words, it's working, right? So I'm teaching you here, you have a patient, here's a scenario. You have a patient that comes into the emergency department and their heart rate's 120 and their blood pressure is high and they're hypoxemic, right? Their oxygen levels in their bloodstream are very, very low. And so you give them a lot of FiO2, you give them a lot of pressure. And then now you start to see their heart rate and their blood pressure return back down to a normal level. That's a sign that the oxygen level in their bloodstream has actually gone up. You've improved their condition. In other words, their body says, oh, you took that hypoxic stress off of me, and now I can slow down my heart rate. I can slow down my perfusion, right? So this can actually tell you if what you're doing is working at the bedside or not, without ever having to draw an ounce of blood out of that patient. I hope that sort of makes sense to you, right? So this is kind of a cool thing to look at. We can do this in critical care as well. If we do a certain maneuver with a ventilator and you start to see their heart rate and their blood pressure go from tachycardic and hypertensive to slow down to a normal level, that can actually be a sign, right, to normal levels, that can actually be a sign that we're being therapeutic, that we've increased the oxygen level in their bloodstream. Okay, so we've talked about perfusion limitation, and then we'll talk here about diffusion limitation. So diffusion limitation is a little bit different. So this is where this one comes into play, especially if your patient has lung disease like pulmonary fibrosis or emphysema, right? Anything that makes the AC membrane thicker. That's why I'm drawing a really thick alveoli there. So this one is for gases that attach directly somewhere to the hemoglobin molecule, right? And that's primarily what we're looking at, is gases that are attracted to the hemoglobin molecule. So oxygen, carbon monoxide, so on and so forth, right? All those gases that attach to the hemoglobin molecule are going to be diffusion limited. In other words, the only thing that stops this gas from going from the alveoli into the bloodstream is how thick or how hard it is to get there in the first place, right? So the thicker the AC membrane, the harder that gas is to diffuse and attach itself to the hemoglobin. Well, why? Why is this not like a perfusion limitation? Because what happens when you have oxygen plus hemoglobin equals oxyhemoglobin. So oxyhemoglobin, once the oxygen binds to the hemoglobin molecule, it does not exert a pressure anymore, right? It does not exert a pressure at all because now it's part of a molecule. It's part of a new relationship, if you will. It has become something different. It's become something that's a part of the red blood cell, if you will. So this one no longer exerts a pressure. So there's nothing here about equilibrium. Nothing here is about equilibrium. The only thing here that we're looking at is parking spots, right? Parking spots on the hemoglobin molecule. The more parking spots we get, that can be helpful. But the only thing that's going to limit how much of this gas, whether it's carbon monoxide or oxygen and so forth, those gases that attach to the hemoglobin molecule, the only thing that's going to limit them from going into the bloodstream is how thick the membrane is. It doesn't matter how much perfusion is going past there, what's going to limit it is the diffusion part, the thickness of that alveoli, right? That alveoli capillary relationship, right? So this one goes right to the erythrocyte, right to the red blood cell. And it has an affinity that is 210 times greater than that of oxygen. So carbon monoxide, once it sees that oxygen, once it sees the hemoglobin molecule, it wants to attach itself greater. It has greater attractiveness to the hemoglobin molecule than the oxygen molecule does. So if you have a situation where if you're breathing, let's just do a little what if situation. What if you were breathing equal amounts of carbon monoxide and oxygen? Don't recommend it. Don't do it. But if you were in theory breathing equal amounts of each gas, your bloodstream would be way more selective to the carbon monoxide, and it would be very hard for your body to get oxygen because that carbon monoxide is much more attractive to that hemoglobin molecule than the oxygen molecule is. So that relationship, even though it's dysfunctional, has a lot more passion behind it. I don't know if that makes sense to it, but hopefully I'm not hitting home with anyone. But when you see this relationship, that hemoglobin and carbon monoxide will definitely want to attract to each other versus the oxygen, and then that's when we have the oxygen being competitive for the binding site, for the hemoglobin site. And so that's where we get the, remember what carbon monoxide is called when it's bound to hemoglobin? It's carboxy. Carboxyhemoglobin is where carbon monoxide binds itself to the hemoglobin molecule. So it's going to be bound to that hemoglobin molecule. Of course, your body needs oxygen, not carbon monoxide. And therefore, your organ systems will actually start to die off because they don't get the oxygen they need to continue to live. So you'll have altered mental status because your brain's not getting a lot of oxygen. Your kidneys will start shutting down. Your liver will start shutting down. We'll go into what's called multi-organ system failure ultimately because our body's not getting that oxygen. So this is very important. These patients with carbon monoxide, their saturation on their hemoglobin is going to be great, but it's saturated with carbon monoxide, not oxygen. And so their body is going to be hypoxic, right? They're going to have tissue hypoxia, and that's going to lead to tissue failure and death ultimately if we don't do anything about it. So remember, once these molecules, oxygen and hemoglobin, or carbon monoxide and hemoglobin, is bound together, they do not exert a partial pressure. So no longer exerts a pressure, right? So there's no such thing as equilibrium here, right? So you're always going to have a pressure gradient. So there's always going to be a higher pressure in your alveoli compared to your bloodstream, right? And compared to your hemoglobin molecule. Both of those are going to be a deficit compared to your P big AO2, the amount of oxygen that's in your alveoli. So that means the only thing that stops diffusion, it's not equilibrium. The only thing that stops that diffusion of gas going into the bloodstream, it'd be how thick that membrane is. And so this is called diffusion limited, right? The only thing that stops it is how easy it is to get from one area to the next area, right? So if your ADA gradient is really, really high, that could be a sign that you might have a diffusion problem, like a thick AC membrane, like we were talking about with that viral pneumonia a second ago, or ARDS, or something like that's going on that can cause that gradient to be off and cause that diffusion to be hurt, right? So blood flow, will it limit the rate of diffusion with carbon monoxide? Absolutely not, because there's always going to be a gradient. Because it no longer exerts a pressure, it does not need equilibrium. The only thing that will stop that gas from going in is how thick that membrane is, right? Or how much surface area that membrane takes up. So with emphysema, we lose surface area. That it just erodes a lot of the alveoli ultimately, and so we're going to have that decreased diffusion in emphysema, right? We're going to have a low DLCO if we're doing pulmonary function testing in emphysema because we lose surface area. And the only reason why their oxygen levels in their bloodstream are so low is because we hurt their diffusion. So your patient that has emphysema, they're going to have a harder rate of diffusion, and the way they compensate is by actually making more red blood cells, right? They want to make more hemoglobin so they can carry it. So you'll see that with people that are chronically hypoxic, they'll have a higher hematocrit, they'll have a higher red blood cell, they'll make red blood cells and become polycythemic, right? Because they need to carry more oxygen, and if they have more hemoglobin molecules, they'll be more efficient at carrying oxygen and make up for this. Because can we fix this AC membrane up here? Can we really fix that scar tissue that formed? Can we fix anything like that that's going on there? Can we fix eroded tissue? Not currently. So the way we have to make up for this, right? You have that patient with emphysema and they're diffusion limited, right? Any lung disease, we're looking at diffusion limitation. So our only way to battle this, especially for people that have emphysema, is to increase their P big AO2, right? To help compensate for that journey that oxygen has to make. So that's why you'll see people with emphysema on continuous oxygen, right? We'll give them a higher FiO2. That'll increase the P big AO2 and therefore help with the concentration. Remember, Henry's law, right? We have to have more pressure up here to diffuse oxygen into our capillary. So we're just using Henry's law here. We're pushing more oxygen by giving them some FiO2. We're giving them some nasal cannula oxygen. So we'll put them on 2 liters of oxygen or whatever it takes to get their bloodstream oxygen level up, just to help overcome this diffusion impairment. So blood flow rate does not limit how fast something like carbon monoxide diffuses. So it will continue to diffuse until the gas is ultimately cut off. So the only thing that will slow the rate of diffusion is if there's a AC membrane defect, right? So this is what we would call a diffusion limited gas flow, right? And so the big take-home point here is, you could experience a carbon monoxide poisoning, right? Especially if you work at a hospital that has a burn ICU or has takes care of patients that have carbon monoxide, that could have carbon monoxide issues. This is very important to you, right? You're going to give them as much FiO2 as possible. If your facility has a hyperbaric chamber, that might be a therapy you might use, right? Hyperbaric, right? Increase that P big AO2 by increasing pressure, right? All these things can help so their body doesn't go into shutdown with carbon monoxide, and so the carbon monoxide should ultimately leave their system when we're looking at it. But this is a diffusion limited gas flow, okay? So it has nothing to do with how high their heart rate or blood pressure or perfusion is. It's all about how healthy the alveolar capillary relationship is, or how thick or thin or how much surface area is on that membrane. All right, so hemoglobin, this is sort of repeating what we went over in the red blood cell PowerPoint. So you have between 4 to 6 million red blood cells, and each red blood cell contains about 280 million hemoglobin molecules. That's quite a bit, right? So adult hemoglobin is 4 hemigroups, and it's pigmented, and it contains iron, right? That's the big thing here, iron. So one of the things that we actually have for patients that are in pulmonary rehabilitation is education, and one of the things that we can absolutely help them with is nutrition. And if we give them iron supplements, now we're not saying make their bloodstream pure iron or anything, but hey, eat something or have a supplement of iron in your blood that might actually help your body be more efficient at what oxygen does go through, right? It might help with more binding of oxygen ultimately. So contains that iron. Remember, the iron is what attracts the oxygen, and that's going to be the big thing, right? One's +2, the other one's -2. Those molecules want to attract, and then that's how they bind together. You're going to have 4 amino acid chains, right? These are their globins. The protein parts are called globins. You're going to have an adult hemoglobin, 2 alpha and 2 beta chains, right? 2 alpha and 2 beta chains. Right? Each one can only hold 4 molecules of oxygen. That's it. That's its maximum carrying. So that's where I use that analogy on the other red blood cell PowerPoint is if we have all 4 molecules of oxygen bind to 1 hemoglobin molecule, then it is 100% saturated. So if you were to check their oxygen level in their bloodstream, right, with a pulse ox or an arterial blood sample, it would show 100% saturated with oxygen. That means all the hemoglobin are taken up with gas. If only 3 oxygen molecules are found on each hemoglobin, then their saturation would be 75%, right? Because this is 75%, or we have 1/4 that's not saturated of the hemoglobin molecule. 50% saturated, it would be only 2 molecules, and so on, right? So we don't just look at one single hemoglobin when we're doing the blood sample of the artery. We don't look at one single hemoglobin, right? One little tiny single hemoglobin when we're using a pulse oximeter, right? That little thing on the finger that tells us heart rate and saturation level. It looks at an entire sample. It averages over the entire amount of blood that's going past the finger if you were using the lasers and the right in the pulse oximeter, or if we draw a sample from your radial artery for an arterial sample, it looks at through that entire blood sample that we drew or that we're looking at through the pulse ox. What's the average, right? That's why when you get an oxygen level through there, it's not 100%, 75%, 50%, 25%, hopefully you would never see, but we're looking at the average of the entire sample. So that's why you'll see someone's saturation levels at 92% or 97% or 88%. That's why it's different, because we're looking at an entire sample and not just one single hemoglobin molecule. So do you think every hemoglobin is always 100% saturated with oxygen? Why? Something to think about. This is where the part where I encourage you to start reading the chapter on this. It's don't get emotionally caught up in this. There's a lot of information in there, but it's very good information. So read it slowly, try to digest it as you read, take breaks. But this is where you start to learn a lot more about how efficient or how oxygen really gets into our bloodstream and how we can be more efficient with it to get it to their tissues. So hemoglobin, oxygen, when it combines with hemoglobin, this is a picture that they even have in the book, becomes its own brand new thing. It's called oxygen. hemoglobin, right? Does it exert a partial pressure? You should say no. When it's bound to hemoglobin, oxygen no longer exerts a partial pressure, right? So just hemoglobin, it's called deoxyhemoglobin or reduced. This means that the hemoglobin is lonely. It doesn't have oxygen bound to it anymore, right? So if there's no oxygen on the hemoglobin, it's called deoxy or reduced, right? I like reduced because it sounds like chemistry-wise. I don't know, I like it. Sometimes hemoglobin's dysfunctional, just like any other relationship out there, right? So hemoglobin can be dysfunctional, and one example here is sickle cell anemia. HBS is what sickle cell anemia here, and here we have an altered shape of the red blood cell. Why does that matter, right? Well, that means there's less surface area, right? And if there's less surface area, it cannot carry as much oxygen. So then they get stuck in the blood vessels. Your capillary in your alveoli, that capillary is smaller, thinner than a sheet of paper, right? It is only enough room for like a red blood cell at a time, right? This is a single lane highway, right? It can get backed up, right? So these get stuck in vessels, especially little arterials, right? Capillaries, and they're easily broken apart as well. So we're going to have a big issue with not only carrying oxygen, but also the destruction that we have with their blood as well. So not only can we not carry it as easily, but also there ultimately is going to be less of them because of the destruction of the red blood cell, because of them breaking apart. They're not as structurally sound as your normal shaped, right, red blood cell. Methemoglobin, we talked about this in the red blood cell PowerPoint. With methemoglobin anemia, right? And this is where the iron in the heme group is altered and the oxygen is no longer attracted to it. So that means it goes from being ferrous, where it's attracted, to being ferric, and it is no longer attracted to it. In other words, it loses its attractiveness with oxygen. So oxygen goes into the bloodstream and it just hangs out. It does not want to attach itself to the hemoglobin. So traditionally their PO2 will be okay, but their saturation, and I'm just telling you clinically, and your book doesn't discuss this, but in real life, clinically, their saturations will be somewhere in the mid-80s, and their blood will be brown when you go to draw their arterial blood. And that's actually a board question too. So hopefully you remember this for many reasons. If you see someone's saturation in the mid-80s and their blood is chocolate brown, and A, give them as much FiO2 as you possibly can, and B, as of recording this, methylene blue, which is used for the Z-Hill-Nelson, the staining for acid-fast staining when you guys are going through microbiology, that's something that we would actually give IV, and I think it's 14 milliliters per kilo or something like that. You'd have to look that up, so don't quote me on that dose. But when we're looking at this, that's something we can give. If we give that methylene blue, it can turn the iron from being ferric back to being ferrous, where it'll attract that oxygen, and therefore we can carry more oxygen in the bloodstream. And remember, the hemoglobin does way more carrying of oxygen in the bloodstream than the plasma does, way more. So when we have a dysfunctional hemoglobin, our ability to deliver oxygen to your tissues, to your brain, your kidneys, so on and so forth, is very diminished. Right? Your ability to get oxygen to where it needs to go severely diminished when we have dysfunctional hemoglobin. Whether it's a sickle cell hemoglobin, HBS, or methemoglobin, MET-HB, right? Those are all issues that we could see there. So this is that sickle cell. I like this picture. I like the little computer picture, but you can see how the crescent shape of it sort of makes for less surface area, and then it can also see how it might be more prone to breaking as it can go through small arterioles and capillaries throughout the body, not just in the lungs, but throughout the whole body. And how old is someone before they might discover this? Right, we're looking at around 3 to 6 months of age, and that's because babies have fetal hemoglobin, right? And that fetal hemoglobin is different. So the sickle cell might not show up until baby is roughly 6 months old, right? Because they have fetal hemoglobin going on in their body. So it's not something they'd be able to catch at birth currently. All right, so when we've looked at this, what determines the amount of gas getting into, right, diffusing into the bloodstream? Well, the characteristics of the gas itself, right? We talked about that with carbon monoxide having a different characteristic than oxygen, the characteristics of the tissues, of course, and of course, partial pressure gradients. So the determinants of diffusion include how much pressure we have in our bloodstream, as well as our alveoli, right? That's the A to A gradient. That's what we're looking at here. The more we increase the P big AO2, the more we increase that diffusion, right? That's Henry's law. Gas characteristics of the tissues, how thick the tissue is, right? That's your diffusion limitation, right? And the characteristics of the gas, that's where we talked about carbon monoxide as well as oxygen, different types of characteristics. All right, so we've talked about gas getting into the capillaries from the alveoli. Well, let's talk about how the oxygen is transported to the rest of the body, right? So I need to see how it's transported from the lungs to the tissues, and then we're going to look at something here called the oxygen dissociation curve. Okay, I'll do a whole separate presentation on that one, but this is pretty much going to look at how easy it is for oxygen to go into the bloodstream, and then it'll reach a certain level where we should be able to give the body enough oxygen, right? So remember, you transport oxygen 2 different ways, both in the plasma as well as on the hemoglobin, right, as oxyhemoglobin. So when we're looking at this here, we need a good relationship between oxygen that's in the plasma as well as oxygen that's attached to hemoglobin. If one of those is low, then we're not going to be going well, right? We need the oxygen content in the plasma to be good, and we also need the oxygen content on the hemoglobin to be good in order to get your body the oxygen it needs. Because remember, when we get to the tissues, you need a pressure gradient. Well, which one of these exerts a pressure gradient? The hemoglobin? Remember, once it's attached to the hemoglobin, it no longer exerts pressure. Or the plasma, P little AO2. PO2, and then I'll do saturation over here. Right? So this is your saturation on the right with hemoglobin and PO2. So once we get to the tissues, what starts the oxygen going into the tissues? How much is on the hemoglobin or the pressure gradient? Well, the pressure gradient is going to start the cascade of oxygen going to your tissues. In other words, your PaO2 needs to be high enough to have a higher gradient than what's in your tissues, so that way you have delivery of oxygen to your tissues. So the PO2 is going to start off, and then once the PO2 decreases, the hemoglobin that has oxygen on it is also going to dump its oxygen to the tissues. So the P little AO2, that's the one I was talking about that last presentation where I said, hey, it's the person that starts the slow clap, right? So we need the P little AO2, even though it's terribly inefficient at carrying oxygen. It's important because we need that pressure gradient in order to coax the oxygen off of the hemoglobin molecule and into the tissue. Okay, so the oxyhemoglobin dissociation curve is going to look at this relationship between pressure and saturation much closer, and we'll do a separate presentation on that. So we can look at how oxygen is transported or how efficient it is by actually doing some calculations, which we will get to do. And even on your board exam, they will ask you to do these calculations. Okay? So I'm not just doing this for my enjoyment, I'm doing this for your future, right? I want you all to be successful. I want you all to get there, right? So we're going to look at transport calculations and content equations that help us tell how the patient's doing. So it'll give us an idea of their cardiac and respiratory status. And then we'll also, at the end of everything, look at the 4 major forms of hypoxia. And that stuff is covered in your chapter as well. So be sure to go through your chapters, be sure to go through your workbooks, be sure to be reading those as well. We do not have unlimited resources to do this all this way. All right, normal values. I will ask you normal values, especially on exam 3 and exam 4 and the final, so get ready. Normal blood gas values. And you say, Derek, why are you making us look at venous and arterial? And I say because in a lot of cases, especially if we're doing a very advanced calculation called the shunt equation, you're going to need to use the venous values and know if those are normal. If we have a patient with severe sepsis, we're going to be looking at venous blood gases. If we have a child, do you want to be poking a child's artery, or would you rather be drawing off of a central line, which is venous, right? I would tell you now, if it was my kid, if we could go off of venous values, please do so. Right? So when we're looking at this, both of these will come in very, very handy, knowing both arterial and venous normal values. So pH for arterial is 7.35 to 7.45. So if it's less than 7.35, it would be acidic. If it's greater than 7.45, it would be basic or alkalotic. Right? Same thing over here for venous. Less than 7.30 would be acidic, and greater than 7.40 would be basic or alkaline, right? So when we're looking at this, you should know normal 7.35 to 7.45 arterial and 7.3 to 7.4 venous. So the only difference is that 0.5, right? 0.05, sorry. 0.05, right, off. All right, CO2 levels. The pressure of CO2 in the artery, 35 to 45 millimeters of mercury. So, and that's P little a CO2, and this is PV CO2 on the right. So P little a CO2 is 35 to 45 millimeters of mercury. Less than 35 millimeters of mercury would be basic or alkaline. Greater than 45, because remember CO2 is a carbonic acid, so that's why a low level would be alkaline. A high level of CO2, which is an acid, would be acidic. Okay, same thing over here, 42 to 48. So 42, less than 42 would be basic. Greater than 48 would be acidic. And you're like, why would I care about the venous CO2 levels? And one of the things that venous CO2 levels can actually tell us about when we compare it to arterial CO2 levels is actually how much tissue metabolism has occurred. It can actually be a sign of tissue metabolism. The higher the metabolic rate of the tissues, the higher the PV CO2 level. Pretty cool. Bicarb. Your book, and this book is very well known for doing it, says the normal level of bicarb in the bloodstream is 22 to 28 for arterial. Less than 22 would be acidic, because remember, bicarb's a base substance. Greater than 28 would be basic or alkaline. So here's the situation. According to a lot of different sources, other than this book, a normal bicarb level is 22 to 26 milliequivalents per liter. 22 to 26. If you answer 22 to 28, I'll have to take it because the book says so. However, on the board exams, you are tested 22 to 26 milliequivalents per liter. So if you want to just get this in your head now that it's 22 to 26, please do so. Just do yourself that favor. 22 to 26 milliequivalents per liter. In the venous, 24 to 30. So 24, anything less than 24 would be acidic. Anything greater than 30 would be basic. And then down here, a PaO2. So PaO2 is pressure of arterial oxygen. PVO2 is pressure of venous oxygen. So PaO2, a normal PaO2, is 80 to 100 millimeters of mercury. Now that's assuming sea level. Okay, and then over here, normal PVO2 is 35 to 45. So when we're looking at this, your oxygen levels are going to be much lower in your venous. The pressure of oxygen levels is going to be much lower in your venous, in your central line, than it will be in your arterial. And this is good. This means your body has used that oxygen, right? That's that metabolic process that we've been talking about. So know your normals. Be ready for the normals. I will ask you that on both this exam and the next one, exam 4 as well. So knowing blood gas values will be coming very handy. It's something you will use every day you practice respiratory therapy, because it is still the standard of care for most situations in critical care medicine. Now, home care, diagnostics lab, that's a whole separate situation, but knowing this is going to help you throughout school as well as on your board exams as well. So even if you plan on never working in acute care, you still need to know it for your time in school here. All right, so how does oxygen get transported? So remember, there's two ways oxygen gets transported. It's either dissolved in the plasma, and that's where we call this P little a O2. P little AO2 is how much oxygen is dissolved in the plasma. It still exerts pressure. That's where the P stands for pressure, right? Pressure of arterial oxygen. And then it also is transported on hemoglobin. So remember, when it's on the hemoglobin, it no longer exerts a pressure, right? And this is where the oxygen is sort of staying on that red blood cell there. So we need both of these. We need a PaO2 and our saturation, right? How much oxygen is saturated on that red blood cell. So we need both of these to transport oxygen. Both of them are important. Both of them are important. All right, so let's look at the dissolving part first, okay? And this is where we're going to start to build some of the equation for oxygen content. So, dissolve. When a gas enters the plasma and keeps its normal gaseous state, in other words, it doesn't combine to anything, it can freely move about and its molecular structure stays the same, and therefore it exerts a pressure, right? So it keeps that pressure, right? And the amount of oxygen that will dissolve is a function of, oh, and I've already mentioned it a couple times, Henry's law. So when we're looking at that, Henry's law is what's going to determine the amount of oxygen that's dissolved in the plasma. What does Henry's law say again? Well, I'm glad you asked, because remember, the bigger the more pressure we have over here on one side, the more will diffuse into the bloodstream. So if we increase P big AO2, right, we're increasing the diffusion ultimately into our plasma, right? So that's Henry's law. That's us increasing the pressure on the breathing machine. That's us increasing the FiO2, right? Increasing the concentration to increase PaO2. That's us decreasing CO2 levels in the alveoli, right? So that's us using that to increase P big AO2 to therefore increase diffusion ultimately. All right, the more pressure there is on one side, the better the diffusion is, right? So if we increase P big AO2, we'll increase diffusion, no matter how sick the alveoli or bloodstream is at that point, right? So it's also based on the solubility as well. When we looked at the solubility, which for oxygen at sea level is 0.244 milliliters per torr, or per millimeter of mercury. All right, so let's continue talking about plasma. So when we measure the amount of oxygen dissolved in the plasma, it's either the artery or the vein. And the vein, now, when I want to talk about this real quick. When we talk about drawing a sample, blood sample from a vein here, to look at how much oxygen, CO2, or pH in a venous sample, we're actually talking about drawing it from usually a central line or a Swan, Gans, catheter, or a balloon-tipped flow-directed catheter is the fancy name your board exams will place it. So that means that the catheter is either close to the vena cava or in the pulmonary artery. Why does that matter? So if I'm drawing a venous sample from a peripheral site, like let's say distal in your hand, right? If I'm drawing a venous sample from the back of a vein in the back of your hand, that tells me about how much oxygen or how much metabolic rate is going on in your hand. It doesn't tell me about your whole body. It tells me about that location. So when the vein is concerned, the location matters. And so that's why it needs to be a central line where it's either in the vena cava, superior inferior vena cava, or usually superior vena cava, or in the pulmonary artery itself. So when we're looking at PVO2s, when we're looking at pressure of venous oxygen, the pressure of venous CO2, the pressure of venous or pH of the venous system, we're looking at a central location like a vena cava or something like that. You're not going to draw it from a peripheral IV, okay? Got that off of it because that tells us more about the whole body's metabolic process, the whole body's consumption of oxygen, the whole body's production of CO2, the whole body's pH after the oxygen's been used. So just so you know, the PVO2 that we're talking about here is drawn from a big site, a central line or a Swan Gans, or also known as a balloon-tipped flow-directed catheter. Okay. So, all right. So, oxygen dissolved in plasma, we looked at in the vein, or we can look at it in the artery. Okay. And when we do this, this is a pressure, right? We're looking at P little AO2 if we're looking at the artery, and this is in millimeters of mercury, right? So when we're looking at that, that's in pressure. Okay, that's great that exerts the pressure, but how much volume of oxygen is going on? I can see how much pressure of oxygen there is in your bloodstream. That's great. But if I gave you a 100 ml beaker, and let's just say there's like 100 ml line right there. Okay, if I gave you a beaker of 100 mLs, and I tell you, and you tell me, right, how much pressure is in there, that means nothing to me. Out of this 100 ml sample, what I want to know, sort of like looking at a graph or a pie chart or something like that, out of a 100 ml sample, how much oxygen in milliliters, right, or volume, right, how much oxygen comprises this 100 ml sample? Of that 100 ml sample, how much oxygen is in there? That tells me more about what's going on in your bloodstream, how much your body is using, or how much your body has available. If we're looking at arterial, how much your body has available. So if I were to get a 100 ml sample of blood, I want to see how much oxygen is available to your tissues. So this is where we're going to take this pressure and we're going to turn it into a volume. I know you're like, I can hear the joy in your hearts right now with what's about to happen. All right, so let's start slowly. So we're still looking at how oxygen is dissolved in the plasma. And so remember when we talked in the red blood cell that we're looking at the maximum amount that can go into that can be pushed onto the hemoglobin molecule, or what's the maximum carrying capacity of a hemoglobin molecule? Well, we also need to know that at body temperature at 37 degrees centigrade, so at BTPS, 0.003, once again, at body temperature, pressure saturated, 0.003 milliliters of oxygen will dissolve in a 100 milliliter sample for every 1 millimeter of mercury. Whew. Okay. What does that mean, Derek? Well, that's where I'm talking about here, where you have this whole beaker, right? And you have 100 mLs, and I asked, okay, you can tell me a pressure, but that doesn't mean anything. How much of this 100 ml beaker of blood actually has oxygen in it? Because then that can tell me how much oxygen is available for the tissues. This is why we're calculating this. I want to see how much oxygen is available to my patient's tissues. That's where we're going with this, right? That's the end goal, right? So don't get caught up in the calculation yet, but understand the end goal is to see how much oxygen is in a 100 ml sample, right? Just to sort of give us an idea how much oxygen is available to the tissues. So when we're looking at a healthy person and we're assuming sea level in normal lungs, their PO2, let's should be around 100 millimeters of mercury. So in order to turn this pressure into a volume, my conversion number is 0.003, right? For every 1 millimeter of mercury, right? For every 1 millimeter of mercury, we're looking up here at the top bullet point. For every 1 millimeter of mercury, 0.003 mLs will go in there. So therefore, to turn this pressure of oxygen into a volume, I need to multiply my pressure times the conversion, 0.003. So if I have a patient that's perfectly healthy and I draw a 100 ml sample of their blood, which we won't, we're drawing a 100 ml sample of the blood, and their PaO2, P little AO2 is 100 millimeters of mercury, then out of that 100 ml container, only 0.3 mLs. So not even a full milliliter. Only 0.3 mLs will be carried in the plasma. That's incredibly low. For as good of a pressure that is over here, that carrying capacity of plasma is very low. So that means 0.3 mLs of oxygen is dissolved for every 100 milliliters of blood plasma. So the units for this, when we do convert this, when this is converted, is going to be known as what's called a volume percent, right? Because it's per 100, percent means per 100, right? And we want to see how much volume is there per 100 ml. So that's where we get the volumes percent, right? So 0.3 mLs for every 100, that's a very low volume percent, right? So how many milliliters are there of oxygen are there in a 100 ml sample, right? So 10 volumes percent, what does that mean? 20 volumes percent, what does that mean? If I have a 100 ml sample here, I have a 100 ml sample and I draw a 100 ml sample, 10 milliliters, 10 volumes percent would mean I have 10 milliliters of oxygen that are hanging around in that 100 milliliter sample. If I have another one here, right, I have a 100 ml sample of blood and I have 20 volumes percent, that means I have 20 milliliters of oxygen hanging out in this beaker of a 100 ml sample. So the higher the content, the higher the volumes percent, the more oxygen content the patient has in their bloodstream. I'll repeat that again. The higher the volume percent, that means that higher the volume percent, the more oxygen content is available in their bloodstream. So you're going to have it on the board exams where they're going to ask you which of the following determines the best way to see someone's oxygen levels in their bloodstream. And they're going to give you some fancy things like P little AO2. And they might even give you P big AO2. And you're like, this is bloodstream, so cross that one off right away. They might say CO2, and they might say saturation. How much oxygen's on the hemoglobin. So far you know, hey, they're asking you which one determines how much oxygen, or what's the best determinant of oxygen content in the bloodstream. Well, P big AO2 is just what's in the alveoli, so I'm going to cross that one out because that could be a diffusion issue. P little AO2 is only the amount of oxygen in the plasma. So that doesn't include what's on the hemoglobin, and we know that most of the oxygen is carried on the hemoglobin, so that's not the best way to look at someone's oxygen level in their bloodstream. Saturation, well, that's only what's on the hemoglobin level. That doesn't include what is in the artery, the pressure of the oxygen in the plasma. So none of these three look at both the pressure of oxygen as well as the saturation of oxygen. There's only one equation that looks at both the pressure in the plasma as well as the saturation on the hemoglobin, and that's your CaO2, right? So this is your content of arterial oxygen, and that's the equation we're starting to learn now. In fact, you've already learned some of it, right? So this equation tells us how much oxygen is dissolved in the plasma when we look at the mLs of oxygen per 100 ml sample. So if we have a patient that has a PaO2 of 70 millimeters of mercury, what does this mean? Well, when we take 70 times 0.003, that gets to 0.21 volumes percent. That means out of a 100 ml beaker sample of blood, so we have a 100 milliliter sample of a patient's blood, less than a milliliter, 0.2, down here at the very bottom, would be oxygen. So that oxygen content compared to that whole sample is very, very low. Okay, so PaO2, when we're looking at how much oxygen is being carried in your bloodstream, is the least helpful, right, in determining how much oxygen is getting to our tissues, right? Very little oxygen is transported in the plasma. Like I said, it plays an important role, but very little oxygen is placed in the plasma. So we need to look at how most oxygen is carried, which is bound to the hemoglobin molecule. Once again, most of the oxygen is transported on the hemoglobin molecule, right? That is going to be a big take-home point. So that means if someone has dysfunctional hemoglobin, if someone's anemic, if someone has blood loss, right? Those are all going to be factors that will determine how much oxygen is carried to their tissues. So that's why if someone's severely anemic, they might have altered mental status, because are they carrying oxygen to their brain, right? Right? So that's going to be one of the big issues. If their blood pressure is really, really low, things like that, all of this is going to factor in how much oxygen is carried to their tissues. So to look at how much oxygen content there is in the artery, we need to look at how much is bound to hemoglobin as well as how much is in the plasma. So let's look at the hemoglobin side of the equation. So normal hemoglobin value, which I will make you remember for an assessment document, for genetic males, 14 to 16 grams per 100, or what's called grams percent, right? Per 100 ml sample, how much mass, or grams, right? How much mass does the hemoglobin take up? For females, 12 to 15 grams per 100 ml, or grams percent, right? So this is the weight or the mass if you extract it from a 100 ml sample. All right, so grams percent, right, is just how much mass there is in a 100 ml sample of blood. So each gram can carry 4 oxygen molecules, and the total is weighed in grams percent. Remember from the red blood cell PowerPoint, each gram of hemoglobin can carry 1.34 mLs of oxygen, right? And that's where I drew a little room, or you can imagine an elevator. And you go into an elevator and it says the maximum occupancy of this elevator is 5, right? And so that's in a perfect situation, okay, that's the maximum amount of people that elevator can carry. So when we're looking at hemoglobin, the maximum amount in volume that the hemoglobin can carry is 1.34 mLs. For every gram of hemoglobin, it can carry 1.34 mLs of oxygen. Okay, so now I need to turn the saturation, or the hemoglobin level of oxygen, into a volume. Well, this is my conversion factor, 1.34. right? And when we're looking at this is going to be ultimately, when we get down the road, 2 volumes percent. All right, so when we're looking at this, here's the example, right? Look at that first yellow example there. If I have a hemoglobin level of 15 grams percent, how much oxygen is bound to hemoglobin? Well, in a perfect situation where every hemoglobin was carrying oxygen, I would just do this. I would take 15 times 1.34, so that turns this gram percent into a volume, right? The milliliters of volume. So if I take 15 times 1.34, I should get roughly around 20 volumes percent, which means if I had this beaker, this 100 ml beaker of blood, if I drew a blood sample that was 100 mLs, 20 milliliters of it would be oxygen. That's great compared to 0.02, right? Remember in the plasma we had 0.02. Now I have 20 milliliters. Much more oxygen can be bound to the hemoglobin than carried in the plasma. So that's perfect. So that means 20 mLs of oxygen in this 100 ml sample. And that's what we call 20 volumes percent. So your unit for this equation is going to be 20 volumes percent. All right, let's do another example for the math people out there that love this. If I have a hemoglobin level of 12 grams percent, and I'm asking you, how much oxygen can this patient carry with the hemoglobin of 12? All you're going to do here is take the hemoglobin level times 1.34, which is the maximum carrying capacity, right? And that tells you how much volume of oxygen can this patient carry with only 12 grams of oxygen, or 12 grams of hemoglobin. So this patient can only carry 16.08 volumes, or 16.08 mLs of oxygen in this 100 ml sample. So that's over here 100, and then this person over here can only hold 16 mLs of this 100 ml sample. So which one's carrying more, the one that has 16 volumes percent or the one that has 20 volumes percent? Well, the one that has 20 volumes percent is carrying a lot more oxygen per the volume of the beaker than this one down here at 16 volumes percent. So this is how much each hemoglobin is capable of carrying if it was perfect saturation. That's if it's perfect saturation, but gotta break some news to you. Most of your patients won't be this perfect saturation situation. So what do? No hemoglobin is not fully saturated on average, right? You have shunting that's left over from fetal circulation. Everyone has it. You have it going on right now. It happens in your coronary circulation, your Thebesian veins, your bronchial pulmonary anastomosis, which we talked about way back in the first week. And you also have shunt-like effects like atelectasis, where some of your lung tissues close down if you're hypoventilating for a little bit, especially if you fall asleep during this video, right? There's a bunch of issues that can also cause some of this to go on. So without supplemental oxygen, we can anticipate hemoglobin to only be roughly around 97% saturated, because we usually have 3% shunting. That's baseline, right? Leftover anatomical shunting. Remember, your heart is pushing down on your lung tissue, and that can create atelectasis, which is a shunt-like effect. So we're going to have a baseline 3% shunt. That's all the time going on. So not all hemoglobin is 100% saturation, right? So saturation, or SaO2, is looking at hemoglobin saturation. Great. I know how to take my hemoglobin times 1.34, but now how do I factor in, when I'm looking at this, how do I factor in the oxygen that's not getting saturated to the hemoglobin? Well, let's look at that. So once we know the amount of hemoglobin, right, we get that from a blood draw, then we multiply it by 1.34, then all I need to do is now take that value times my saturation in a decimal form. Okay, so here's the equation for looking at how much oxygen is on your hemoglobin. And I might ask you on an exam, tell me how much oxygen is on this patient's hemoglobin. Okay, this is what you would be doing. You're going to take their hemoglobin level times 1.34. Then you're going to take that times their saturation. That equals how many milliliters of oxygen in a 100 milliliter sample are being carried on their hemoglobin. Here's the example. All right, I have a patient. Their hemoglobin level is 15 grams percent. Their conversion factor is normal. That's a constant, right? And their saturation is 97%. Okay, so notice here, here's a place where people make mistakes. All right, is they put the saturation as a 97 instead of 0.97, right? So if it was 0.85, that would be 85% saturated. So if it was 0.30, it would be 35% saturated. So notice that with this equation, you put the percent in a decimal form, right? The percent goes in a decimal form. So in this patient, we take 15 times 1.34 and then take that times 0.97. So that gets rid of that 3% that anatomically is shunting. So on this patient, right, this is where we get 19.5 volumes percent. And that's the unit I want you to use, which means, right, this is just telling you what this means over here. 19.5 milliliters of oxygen in that 100 ml blood sample are bound to hemoglobin, right? How much is bound to the hemoglobin? But is bound to the hemoglobin the only way oxygen carried or transported? No, right? You know that it's also carried in the plasma. So this is the CaO2 equation, the total content of arterial oxygen, the CaO2, right? This is how much oxygen is carried in the plasma added to how much is carried on the hemoglobin. So we want to connect these two together. If I ask you, what's the best way to see how much oxygen there is in the bloodstream? You're going to say the CaO2 equation because it combines the oxygen content of the plasma as well as the oxygen content that's on the hemoglobin molecule. It combines both of those. We're adding both of those together. So this is the equation. We're going to take their hemoglobin times 1.34 times their saturation, remember in a decimal form, right? So we're taking that and then we're going to add it to whatever their PaO2 is times 0.003. This is the CaO2 equation. And a normal value, and I encourage you, right, remember I talked to you guys about having a list of equations and writing your normals next to them, right, with the units as well. A normal CaO2, a normal arterial oxygen content is 20 volumes percent, right? That's a normal level. That's the correct unit, 20 volumes percent, which means if I were to draw a 100 ml sample of blood from a patient, and then I were to look at that blood and see just overall, not how much is in the plasma, not how much is on the hemoglobin, but how much oxygen both in the plasma and on the hemoglobin is being carried in their blood, that normal would be 20 mLs of that sample. So 20 mLs of oxygen would be carried in that 100 ml sample of both the plasma and the hemoglobin together. All right, so here is an example. Right here is something you guys need practice, and there's worksheets. I believe they're under day 10 when I'm recording this. There's worksheets that looking at the content. There's one that says content equations. That's the one that I would practice with here, right? Don't go for the other one, the delivery and the O2ER and all the other stuff. Go for the one that says content, right? So here's a one to do together. We have hemoglobin that's at 15 grams percent. Their saturation is 95%, and their PO2 is 90. Okay. So my equation, I'm going to take 15 times 1.34 times 0.95. right? If you do this, you should get 19.10. Then I'm going to add it to what's in my plasma. So if I take 90 times 0.003, I should get 0.27. When we do this, we add these two together, because that's what we're looking at, is how much is in the plasma and how much is on the hemoglobin. When we add those two together, we should get 19.37 volumes percent. Which, let me ask you this, is that a normal value? It's pretty darn close to it, so we'll call that pretty close to a normal value. It's within 10%, ultimately. So when we're looking at this, most of that oxygen, where did it come from? Right? What had more content in it? The plasma level of oxygen or the hemoglobin level of oxygen? Well, of course, 19.10, we carry a lot more oxygen here, right? And that's why getting people blood in a massive blood loss and dysfunctional blood, it can be very useful in helping improve their oxygen levels in their bloodstream, right? Okay. Whew. So we've gone over what the content of arterial oxygen is and how to calculate it. I hope you just practice doing those equations. Practice, 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 right? We can also look at how much content of oxygen there is in the venous side. And you're going to love this, right? This is my favorite part, is breaking this news to you. It's the same equation, but we're just going to plug in venous values, and so there's a little thing to make. So same equation, right? So we get this from the pulmonary artery, or if they only have a central line, you can get it from a central line as well. SGC is the Swan Gans catheter, also known as a balloon-tipped flow-directed catheter. That's the one that can go into the pulmonary artery. Now, there are some patients that, and a lot of patients, there are more risks associated with a Swan Gans catheter than there is with the central line, so they're not as common as they used to be. So that's why you might only have to have it a central line. So as close as you can get to the lungs, that's where you want to be. So a central line or Swan Gans if they do have it. So with this one, it's the same equation, but we're just going to use venous values. So hemoglobin times 1.34 is the same, but this should say SVO2, right? So if you have your notes in front of you, put SVO2 there. So your venous saturation of oxygen. So remember, this is what's on your hemoglobin, and then you're going to add to what's in their plasma, which is the pressure of venous oxygen times 0.003. So when we're looking at this, right, and this will still be in volumes percent, and a normal CVO2, content of venous oxygen, is 15 volumes percent. 15 volumes percent. So a normal CaO2 is 20 volumes percent. A normal CVO2 is 15 volumes percent. That means the normal metabolism, or the normal gradient between arterial and venous, is 5 volumes percent, right? You're going to use 5 volumes percent of oxygen for tissue metabolism, right? For cellular respiration, right? Those fancy words we talked about first slide of day 1, right? So when we do this, we're looking at how much oxygen's in the vein, right? How much oxygen's in the vein? How much oxygen was in the artery? Okay, so that's great. It tells us the vein and the artery. Well, that's not the only place we can actually look at oxygen content. There's a third place besides looking at the vein and looking at the artery that we can see oxygen content, right? So we can calculate, we're not going to stab anybody's lungs here, but we can calculate how much oxygen there is in the pulmonary capillary. And this is what's known as your CCO2, your capillary content of oxygen. So good news, this equation is also very similar. But instead of saturation, because we can't stab the lung, you should not do that, by the way, you're just going to do the hemoglobin times 1.34, and then take your P big AO2 times 0.003. Because remember, we're looking at pulmonary capillaries. So is there a way we can look at pressure of oxygen in the pulmonary capillary? Yeah, that's our alveolar air equation. You're like, Derek, that means I got to do, for the CCO2, I have to do the alveolar air equation? And my answer is yes, right? That's the only way of seeing that. Here's the some more good news. I love doing the alveolar air, but here's the more good news. Is this normal CCO2 is also 20 volumes percent. It's the same as CaO2. Why? Why is that? This is a point where I talk about, hey, it's good to look in your chapter.